I want you to imagine, just for a moment, that you are sitting in this massive, really ornate cinema.
Right, like the old school ones with the heavy red velvet curtains.
Exactly. The lights have gone down, you've got your popcorn resting on your lap, and you are just totally engrossed in the film playing out on the silver screen.
You're completely lost in the narrative.
Yeah. But suddenly the picture starts flickering. And I mean violently flickering.
Oh, like the colors completely invert, turning all the actors into these strange negative ghosts.
Right. And the audio warps into this terrifying, distorted screech. So your natural instinct, and like the instinct of almost everyone else in that cinema, is to just stare at the screen.
Of course.
You might even feel the urge to walk up to the front, stand on the stage, and try to fix the canvas itself.
I like maybe smooth out the fabric or check the tension of the ropes holding it.
Yeah, assuming the screen itself is the source of the chaos.
Yeah.
But the screen is just the manifestation. The actual problem is a dying bulb or maybe a frayed sparking wire in the heavy mechanical projector sitting all the way at the back of the room.
Hidden behind that little glass window.
Exactly.
It's a really compelling image, and it perfectly encapsulates this philosophical trap we frequently fall into in medicine.
How so?
Well, if you spend all your time trying to repair that canvas, smoothing out the fabric of the patient's immediate behavior, you are completely ignoring the machinery that is projecting the image.
Right.
In our field, we really need a guiding philosophy that corrects this oversight. We have to frame psychiatry with extreme precision.
Because we aren't just, cataloging emotions or debating abstract thoughts.
Exactly. Psychiatry is the rigorous study of how the brain, the mind, and experience interact. And crucially, the study of how that complex, delicate process can go catastrophically wrong.
And that framework is really the core mission of today's deep dive. We are exploring the concepts laid out in Chapter 7.6 of Kaplan and Sedok's comprehensive textbook of psychiatry.
It's a fantastic chapter.
It really is. The goal of this deep dive is to train ourselves to turn around and look at the projector rather than staring blindly at the screen.
Right.
Like when a patient presents with a severe, undeniable psychiatric symptom, let's say an acute manic episode out of nowhere, or profound, terrifying psychosis, or a crushing treatment-resistant depression, how do we actually know the body isn't the true culprit?
You don't, not right away.
Yeah, how do we know we aren't looking at a frayed wire in the patient's metabolic engine, projecting a ghost onto the canvas of their mind?
We approach it by building resilient, structurally sound mental models. Assuming a psychiatric symptom has a purely psychiatric origin, or we might call it primary psychiatric illness, is perhaps one of the most dangerous, potentially lethal assumptions a clinician can make.
Wow. Lethal?
Absolutely. The mind and the body are not two separate entities operating in adjacent rooms. They are deeply, deeply intertwined systems.
So our discussion today is meant to serve as a conceptual companion to your own reading of the text, to really strengthen your clinical reasoning so you don't miss that frayed wire.
Yes.
So if we know the body can mimic the mind, if a biological malfunction can look exactly like schizophrenia or major depression, the natural instinct, especially for someone fresh out of medical school, is to test absolutely everything.
Oh, the shotgun approach.
Yeah. You admit a patient to the psychiatric ward, and you just order every single laboratory test under the sun. You cast a massive net.
Right.
But the text makes a point to tear down this instinct. Why is this routine testing considered such a clinical trap? I mean, I would think that casting a wide net catches more fish.
That is a very common assumption. But it ignores the mathematical reality of diagnostic testing. Have you ever encountered Bayes' theorem or the concept of pretest probability?
I mean, I know it has something to do with the maths of a result being true based on, how likely the event was in the first place.
That's the absolute essence of it. Let's break it down mechanically. Modern medical education often inadvertently trains physicians to reflexively order vast panels of bloods.
Especially upon an inpatient admission.
Exactly. It's comforting to have data. But ordering broad, indiscriminate screening tests in populations that are otherwise medically asymptomatic rarely uncovers hidden, clinically significant diseases.
Why is that?
Because every single laboratory test has a false positive rate. If you order 50 different blood tests on a healthy person, the statistical probability that at least one of those tests will come back abnormal purely by chance is incredibly high.
Oh, I see. So if I have a condition that affects, say, 1 in a million people, and I use a test that is 99% accurate on 1,000 healthy people, I'm going to get 10 positive results.
And every single one of them will be a false positive.
That's wild.
And in medicine, a false positive is not just a statistical quirk. It is an active vector for harm.
Because you have to act on it.
Exactly. An abnormal result on a shotgun screening panel forces the clinician to investigate. This leads to more invasive testing, unnecessary specialist consultations, profound anxiety for the patient, and a massive waste of healthcare resources.
Right.
The fundamental rule of medical assessment is this. A test should only be ordered if the result has the potential to alter your management of the patient.
That makes perfect sense.
If a result comes back abnormal, but you are not going to change your treatment plan, you really had no business ordering the test.
Okay, let's unpack this. So instead of fishing with a massive net and hoping we catch a diagnosis and pulling up a bunch of old boots and false positives, we need to be spearfishing.
Spearfishing, I like that.
I need to be intentional. But if we aren't relying on a massive panel of bloods to tell us what is wrong with the projector, where do we actually start? How do we know where to aim the spear?
You start with the most powerful, underutilized diagnostic tool we have. The history and the physical examination. That is your foundation. The history of the presenting illness, the past psychiatric and medical history, the social history, even seemingly obscure details like toxic workplace exposures.
So you're building a profile.
Yes. You derive clinical hypotheses from the specific data this particular patient gives you, and then you order a narrow, targeted selection of tests to either confirm or refute those specific hypotheses.
Okay, let's zoom in on that physical examination, because the text points out that the patient's body is an absolute gold mine of data, particularly when it comes to substance abuse.
It really is.
We rely so heavily on patient self-reporting in psychiatry, which, let's be honest, can be fiercely unreliable due to shame, stigma, or cognitive impairment.
Right. Patients aren't always going to give you a perfect history.
So if we're examining the physical body, what specific, undeniable clinical clues are we looking for?
The skin and the mucous membranes will often tell a story that the patient is desperately trying to hide. Take intravenous drug use, for example. The classic sign is track marks. Those linear, hyperpigmented, small scars that follow the anatomical outline of a superficial vein, usually in the antecubital fossa of the arm.
The inside of the elbow.
Yes. But chronic users run out of viable veins. The veins collapse and sclerose. So they change their administration route.
They move to skin popping, right?
Yes, skin popping. That is the subcutaneous injection of drugs. The patient injects the substance directly into the fat layer under the skin rather than into a blood vessel.
Oh, wow.
Because illicit drugs are highly irritating and non-sterile, this causes localized tissue necrosis and microabscesses.
That sounds incredibly painful.
It is. And when these heal, they leave behind very characteristic hyperpigmented, fibrotic, depressed, round papules, typically scattered across the forearms or the lower legs.
So if you see those circular, darkened indentations, you are looking at a history of subcutaneous substance use.
Unmistakably.
And what about patients who insufflate or snort their drugs? Cocaine is the classic example here.
Cocaine is a highly potent vasoconstrictor. When you insufflate cocaine, it coats the mucous membranes of the nasal passages and clamps down the local blood vessels, severely restricting blood flow to the tissue.
Right.
If this happens chronically, the tissue is repeatedly starved of oxygen, a state of local ischemia. Over time, the tissue literally dies and slashes away.
Oh, grim.
It begins as chronic, unexplained nosebleeds and eventually progresses to a total perforation of the nasal septum. You can shine a pen light up one nostril and see the light shining clearly through to the other side because the dividing wall of cartilage has completely eroded away.
That is visceral.
Yeah.
But it makes the biological mechanism so clear. The drug starves the tissue of blood.
Exactly.
Now, the text draws a massive critical distinction between the physical signs of intoxication versus the physical signs of withdrawal.
This is a vital distinction.
Let's look at opioids, because getting this wrong can severely compromise patient care. How do we differentiate intoxication from withdrawal purely by observing the patient's physiological state?
It is essentially a complete physiological reversal. To understand it, you have to look at the autonomic nervous system.
Okay, the fight-or-flight system.
Right. Opioid intoxication profoundly depresses the central nervous system. The sympathetic nervous system, your fight-or-flight response, is effectively turned down to a whisper.
So everything slows down.
Exactly. The patient will present with profound sedation, slurred speech, dysarthria, and slowed cognition. And the hallmark physical sign is pinpoint pupils, or meiosis.
Meiosis.
Yes. The parasympathetic system is unopposed, restricting the pupil to the size of a pinhead.
But when they stop taking the opioid, the body doesn't just return to normal right away, does it? It swings violently in the opposite direction.
That's the mechanism of withdrawal. Because the central nervous system has been artificially suppressed for so long, the body has upregulated its sympathetic receptors to try and maintain balance.
Like pushing harder on the accelerator because the brakes are stuck on.
Exactly. So when the opioid is suddenly removed, the brakes are cut, you get an explosive rebound of the sympathetic nervous system. It's an autonomic storm. The locus coeruleus in the brainstem floods the system with noradrenaline.
So it looks like a massive panic attack on a systemic level.
Much worse. The patient will experience profound lacrimation, which is excessive tearing from the eyes, and severe rhinorrhea, a constant runny nose.
Like a terrible flu.
Yeah, they will have intense muscle aches or myalgias and frequent yawning. They develop piloerection goosebumps covering their skin, which, as a historical aside, is actually where the colloquial phrase cold turkey originates. Their skin resembles a plucked turkey.
Wait, really? That's where that comes from?
It is. And those pinpoint pupils, the sympathetic surge causes massive pupillary dilation known as mydriasis.
So huge pupils. And the timing of this autonomic storm is completely dependent on the half-life of the drug they're using, right?
Yeah, absolutely. If a patient is using short-acting opiates like heroin, the drug clears the receptors quickly, and this horrific withdrawal cascade begins just 6 to 12 hours after their last dose.
That is so fast.
It is. If they are on a longer-acting agent like methadone, the drug slowly detaches from the receptors, and it might take 1 to 2 full days for these intense signs to appear.
This entire discussion of the physical exam highlights something vital. As psychiatric clinicians, we occupy a dual role.
We do?
Yes, we are treating the acute, affective, or psychotic illness in front of us, but we're also uniquely positioned to monitor physical health and prevent future impairment.
That is a crucial point.
And the morbidity and mortality statistics provided in the textbook are, quite frankly, staggering.
They are deeply sobering, and they really reframe our professional responsibility. Patients with severe chronic psychiatric illnesses suffer from significant premature mortality. Their life expectancy is substantially shorter than the general population.
It's tragic.
And crucially, it is not always from the direct consequences of the psychiatric illness itself, like suicide or misadventure.
Right.
They are dying from a small number of chronic lifestyle-related clinical problems. Profound obesity, poorly managed type 2 diabetes, and aggressive cardiovascular disease.
The statistic that forced me to pause my reading was regarding bipolar disorder.
It's a striking data point. In patients with bipolar disorder, comorbid cardiovascular disease leads to greater mortality than suicide.
That is incredible. We spend so much clinical energy assessing suicide risk, as we absolutely should. But the silent killer is the atherosclerotic plaque building up in their coronary arteries.
Yes. And this cardiovascular disease occurs at a significantly younger age in this population than in the general public without mental illness.
Why is that?
It's driven by a combination of genetic vulnerabilities, lifestyle factors like high smoking rates and poor diet, and unfortunately, the metabolic side effects of the very medications we prescribe.
So a psychiatric admission isn't just about stabilizing mood. It might be the only time this patient interacts with the healthcare system all year.
Precisely. It is an obligation. Checking fasting lipid panels, measuring hemoglobin A1C, actively counseling on smoking cessation, screening for hypertension.
It's a rare opportunity to deliver targeted preventative care.
Because aggressively treating these medical complications doesn't just extend their lifespan. The literature shows that reducing this allostatic load actually lessens the severity and frequency of their affective and psychiatric symptoms.
Because the mind and the body are completely intertwined.
Exactly.
Which provides the perfect bridge into understanding the internal environment. We know the body can mimic the mind, and we've established how to look for external clues on the skin and in the eyes.
Right.
But let's look under the hood. How exactly do microscopic biological shifts alter complex behavior in human cognition? Let's explore the physiological interlopers.
Let's do it.
Starting with what we might call the electrical brain, our electrolytes. Here's where it gets really interesting. How does something as seemingly simple as salt or potassium completely change a person's reality?
To understand this, we have to look at the foundational biology of a neuron. The brain does not communicate via magic.
I would hope not.
It communicates via electrical action potentials. These action potentials are generated by maintaining a very precise voltage difference across the cell membrane.
Okay, a voltage difference.
And that voltage is entirely dependent on the precise balance of positively and negatively charged ions electrolytes, like sodium, potassium, calcium, and magnesium inside and outside the neuron.
So it's literally an electrical circuit.
Yes, if you alter the concentration of these electrolytes in the blood, you alter the electrical firing threshold of the brain, the peripheral nerves, and the heart.
Let's tackle potassium first. Hypokalemia, a state of low serum potassium. In a psychiatric context, who are we most worried about here?
You must maintain an incredibly high index of suspicion for hypokalemia in patients with eating disorders.
Right.
Specifically, those who engage in purging behaviors, self-induced vomiting, or those who abuse laxatives or diuretics to lose weight.
That makes sense. They are actively depleting their fluids.
You will also see it in psychogenic vomiting. Every time a patient vomits, they lose gastric acid. This triggers a complex renal cascade where the kidneys dump potassium into the urine to try and maintain the blood's pH balance.
Oh, so the body sacrifices potassium to keep the acid-base balance stable.
Exactly. And behaviorally, profound hypokalemia manifests as severe, unremitting weakness, lethargy, and fatigue because the muscle cells cannot properly depolarize.
But the real terror of hypokalemia isn't just that the patient feels tired. It's what it does to the electrical system of the heart.
Yeah.
What is the clinical marker we are hunting for on an electrocardiogram, the ECG?
We are looking for very specific repolarization abnormalities. Potassium is the key ion responsible for resetting the heart muscle's electrical charge after a contraction, a phase called repolarization.
The reset phase.
Right. When total body potassium is depleted, the heart muscle struggles to reset. It takes longer.
So how does that look on the tracing?
On a surface ECG, this delayed, struggling reset visualizes as flattened T waves, a depression of the ST segment, and the emergence of a highly specific waveform called a prominent U wave, which appears right after the T wave.
So if I'm looking at an ECG of a 20-year-old with anorexia nervosa who frequently purges, and I see a prominent U wave.
You are looking at a heart that is electrically unstable. That U wave indicates a prolonged, vulnerable period in the cardiac cycle.
Vulnerable how?
If a premature beat hits the heart during that specific fraction of a second, it can trigger a fatal ventricular arrhythmia. It is a massive red flag.
That is terrifying. Let's move to magnesium. I feel like magnesium is the forgotten electrolyte, but the text highlights its critical importance.
It really is forgotten. Hypomagnesemia is a classic dangerous finding in patients with severe chronic alcohol use disorders, as well as those with severe malnutrition.
Why alcohol specifically?
Alcohol essentially acts as a diuretic for magnesium. The kidneys just waste it. Furthermore, magnesium naturally blocks the NMDA receptors in the brain, which are excitatory.
Oh, so it keeps the brain calm.
Exactly. When magnesium levels plummet, those receptors become unblocked and hyperexcitable. This destabilizes the entire central nervous system.
Leading to what?
Severe agitation, confusion, and frank delirium. If it remains untreated, this electrical hyperexcitability progresses to generalized convulsions and eventually coma.
And does it affect the heart like potassium does?
Yes, and arguably in a more terrifying way. Low magnesium fundamentally prolongs the QT interval on an ECG. This increases the risk for a specific, chaotic, and often deadly polymorphic ventricular arrhythmia called torsades de pointe.
We will definitely dig into torsades in detail when we discuss medication monitoring. For now, let's talk about sodium. Hyponatremia. This seems like the ultimate clinical masquerader, especially in older adult populations.
Sodium dictates fluid balance. Water follows sodium through a process called osmosis. If the sodium concentration in the blood drops, which is hyponatremia, the blood becomes dilute compared to the inside of the body's cells. Because water wants to balance the concentration, it rushes out of the bloodstream and into the cells, causing them to swell.
But the brain cells are trapped inside the rigid human skull. They can't expand.
Exactly. The cranium has a fixed volume. When neurons and glial cells in the brain swell with water, it increases intracranial pressure and physically disrupts neuronal function.
So what causes this drop in sodium in a psychiatric setting?
You see severe hyponatremia and psychogenic polydipsia. This is a condition often seen in severe chronic schizophrenia, where patients compulsively drink massive, literally lethal amounts of water, diluting their blood.
But it's not always a behavioral compulsion, is it? can be a side effect of our own treatments.
Yes, we frequently induce it via medications. Drugs like oxcarbazepine, carbamazepine, and several SSRI antidepressants can trigger a condition called the syndrome of inappropriate antidiuretic hormone, or SIADH.
How does that work?
The brain mistakenly releases a hormone that tells the kidneys to hold on to free water, diluting the sodium in the blood.
And how does this actually manifest in the clinic? What does a waterlogged brain look like behaviorally?
It looks like profound cognitive slowing, lethargy, confusion, or frank delirium.
And you mentioned older adults.
Yes, the tragic clinical trap here is ageism. An older adult might be prescribed an SSRI or oxcarbazepine, and a few weeks later they present with severe cognitive slowing and confusion.
And the doctor just assumes it's dementia.
Exactly. A clinician might look at their age and mistakenly diagnose them with rapid onset dementia or severe psychomotor retarded depression, when in reality their serum sodium has simply plummeted due to a medication side effect.
If you don't check the basic metabolic panel, you miss the diagnosis entirely.
You completely miss it.
That is a perfect example of looking at the screen instead of the projector. To finish out the electrical system, let's look at calcium and phosphorus. They operate on this inverse relationship, like a seesaw in the blood.
They do. The parathyroid glands constantly monitor calcium levels and adjust phosphorus excretion to maintain a delicate balance. And these levels tie directly into neuropsychiatric function.
How so?
Hypocalcemia, abnormally low calcium, is strongly associated with profound depression, irritability, and delirium. Conversely, hypercalcemia, high calcium, is associated with a different spectrum: severe depression, profound physical weakness, and full-blown psychosis.
I remember the medical school mnemonic for high
Yeah.
calcium. Stones, bones, abdominal groans, and psychiatric overtones.
That's the classic one, yes.
And again, psychiatrists can inadvertently cause this hypercalcemia, can't we? It's not always organic disease.
We absolutely can. Chronic long-term treatment with lithium, which is a phenomenal mood stabilizer, can unfortunately induce hyperparathyroidism.
How does lithium do that?
The constant presence of lithium essentially tricks the parathyroid glands into a state of hypersecretion. They pump out excessive parathyroid hormone, which acts on osteoclasts to tear down bone tissue, pulling calcium out of the skeleton and flooding the bloodstream with it.
So if you have a patient who has been wonderfully stable on lithium for a decade, and they suddenly develop cognitive dulling, bone pain, and lethargy,
You cannot assume it is a bipolar depressive relapse. You must check their serum calcium.
okay, so we've mapped out the electrical system. Now let's move to the metabolic engine specifically, hepatic and renal function.
Right.
The textbook explains a pharmacokinetic concept here that I think is absolutely vital for any clinician prescribing medications. Hepatic protein binding. Can you break this physical chemistry down for us?
This is pharmacology at its most elegant, and ignoring it is incredibly dangerous. When a patient swallows a psychotropic medication, it is absorbed through the gut and enters the bloodstream.
Okay.
But it doesn't just float around freely in the plasma like salt in a glass of water. Many of our psychiatric medications are highly protein-bound. This means the drug molecules physically attach themselves to specific proteins circulating in the blood.
What kind of proteins?
Primarily a protein called albumin, which is manufactured by the liver.
I always think of albumin like a fleet of cargo ships navigating the bloodstream.
That is an excellent analogy. When the drug molecule is attached to the cargo ship, when it is protein-bound, it is pharmacologically inactive.
Why is that?
It is too large and bulky to cross the highly selective blood-brain barrier. Only the free, unbound fraction of the drug, the molecules that aren't on a ship, are active and able to slip into the brain to exert their therapeutic or toxic effects.
So when a pharmaceutical company calculates the standard dosage guidelines for a drug, they are assuming the patient has a normal, healthy fleet of cargo ships to absorb a specific percentage of that dose.
Exactly.
What happens if those cargo ships just aren't there?
That is where the catastrophe occurs. If a patient is severely malnourished, like a patient with severe anorexia nervosa, or if they have significant liver disease from chronic alcohol abuse, their liver simply stops manufacturing albumin.
So their total serum protein drops.
Yes. Now, imagine you prescribe a normal, standard, guideline-approved dose of a highly protein-bound medication like diazepam or valproate. You've put a massive amount of cargo into the blood, but there are no ships to carry it.
Because there's nothing to bind to,
Yeah.
a massive, unpredicted fraction of the drug remains unbound.
Precisely. The free fraction of the drug skyrockets. You end up with severe, life-threatening neurological toxicity, profound sedation, and respiratory depression, even though you prescribed exactly what the textbook suggested.
A normal dose suddenly becomes a massive overdose because the patient's internal transport mechanics are broken.
This is exactly why you must check a comprehensive metabolic panel, specifically total protein and albumin in malnourished or alcoholic patients before initiating highly protein-bound therapies.
The liver is our primary detoxification plant. It manufactures proteins, but it also clears out the garbage. What happens when it fails to clear ammonia?
Ammonia is a highly toxic nitrogenous byproduct of normal protein metabolism. A healthy liver takes this toxic ammonia and runs it through the urea cycle, converting it into harmless urea, which is then excreted by the kidneys in our urine.
But a failing liver can't do that.
No, a failing cirrhotic liver cannot run this cycle efficiently. The ammonia backs up, builds to high concentrations in the blood, and easily crosses the blood-brain barrier.
And ammonia is essentially a neurotoxin.
It is. In the brain, astrocytes try to buffer the ammonia by converting glutamate to glutamine, which causes the astrocytes themselves to swell, leading to cerebral edema.
Brain swelling.
Yes. This entire cascade results in hepatic encephalopathy. Behaviorally, it presents as a profound, fluctuating delirium. The patient might have inverted sleep-wake cycles, bizarre personality changes, and a classic physical sign called asterixis.
Which is a flapping tremor of the hands, right?
Correct. And crucially, you will also see hyperammonemia occasionally as a rare but severe complication of valproate therapy, even if their liver enzymes are normal.
Speaking of liver enzymes, when we are checking liver function tests, or LFTs, the text is very specific about looking for patterns of injury, not just high numbers. Let's talk about the AST to ALT ratio.
AST and ALT are aminotransferases. They are enzymes that live inside the liver cells, helping to metabolize amino acids. When a liver cell is damaged and bursts open, it spills these enzymes into the blood.
So high numbers mean liver cell death.
But the ratio tells you the cause. AST is found heavily in the mitochondria of the cell, while ALT is mostly in the cytoplasm.
And alcohol is a mitochondrial toxin.
Exactly. Chronic alcohol abuse obliterates the mitochondria inside the liver cells. Therefore, disproportionately more AST is spilled into the blood than ALT.
I see.
If the AST to ALT ratio is 2-to-1 or greater, it strongly suggests alcoholic liver disease. And if that 2-to-1 ratio is accompanied by a severely elevated gamma-glutamyl transpeptidase, or GGT, that specific tripartite pattern is almost pathognomonic for alcoholic liver injury.
It's a chemical fingerprint of alcohol abuse.
Yes, it is.
Okay, we've covered the electrical and the metabolic engines. Let's look at the endocrine messengers, the hormones. The thyroid gland, sitting right at the front of the neck, is often called the great mimic in psychiatry. What is the mechanism behind that?
Thyroid hormones, primarily T3 and T4, are essentially the master thermostats for the body. They dictate the basal metabolic rate of almost every single cell, including the billions of neurons in the brain.
So what happens if the thermostat is broken?
If you don't have enough hormone hypothyroidism, a sluggish thyroid, the brain's metabolism grinds to a halt. This looks exactly like a severe melancholic depression.
What are the symptoms?
The patient presents with profound physical fatigue, significant weight gain despite poor appetite, psychomotor and cognitive slowing, and cold intolerance.
And if the thermostat is turned up too high?
Hyperthyroidism. The cells are in metabolic overdrive. This mimics a severe anxiety or panic disorder, complete with rapid weight loss, resting tachycardia, a fine tremor, and heat intolerance. The patient might feel like they are vibrating out of their skin.
The golden rule the text provides here is stark. You cannot achieve euthymia if a patient is not euthyroid.
It is a brilliant, undeniable axiom. Euthymia means a normal, stable mood. Euthyroid means normal thyroid function.
So you have to fix the thyroid first.
No amount of SSRIs, SNRIs, or electroconvulsive therapy will fix a depression that is fundamentally caused by a failing thyroid gland. You must replace the missing hormone with levothyroxine. The psychiatric symptoms are secondary to the endocrine failure.
What about the adrenal glands? They sit right on top of the kidneys and pump out our stress hormones.
Cortisol is the primary player here. It regulates metabolism, reduces inflammation, and manages the stress response.
So what happens when cortisol levels are off?
Too little cortisol, a condition known as Addison disease, causes a gradual, insidious onset of profound fatigue, anorexia, weight loss, and severe depression. It is often mistaken for a somatic symptom disorder or atypical depression.
And too much.
On the other end, too much cortisol Cushing syndrome, which can be caused by a pituitary tumor or by taking heavy doses of corticosteroid medications, causes extreme mood lability, profound irritability, paranoia, and even acute hospitalizing mania.
Really? Mania?
Yes. Roughly half of all patients with Cushing syndrome will develop clinically significant psychiatric symptoms.
The endocrine system is so potent. Lastly, in this section, I want to touch on the pancreas. The text makes a really nuanced, specific point about amylase and lipase that feels like a classic board exam trap, but also a crucial clinical distinction.
Oh, this is a great point.
Pancreatitis is an inflammation of the pancreas, often caused by chronic alcohol abuse, but rarely it can be a catastrophic side effect of psychotropics like clozapine or valproate.
Yes, and typically if a patient presents with severe abdominal pain radiating to their back and you suspect acute pancreatitis, you check serum amylase and serum lipase.
Which are digestive enzymes.
Right. And in true pancreatitis, both will be highly elevated in the blood. However, there is a massive diagnostic trap here when you are dealing with patients who have eating disorders.
Because they purge.
Exactly. Patients who routinely purge via self-induced vomiting will almost always have chronically elevated serum amylase.
Why is that?
But this isn't pancreatic amylase leaking from a damaged organ. It is salivary amylase. The salivary glands in the mouth are pushed into absolute overdrive by the constant mechanical act of vomiting, and they spill excess amylase into the blood.
So if a patient with bulimia nervosa comes into the A&E complaining of vague abdominal pain and you check their amylase, it will be high.
It will be very high.
If you don't know the mechanism, you might rush them to a surgical ward for pancreatitis.
You might. If you want to know if their pancreas is actually inflamed, you must check the pancreatic lipase. Lipase is specific to the pancreas.
Okay.
In a purging patient without true pancreatitis, the amylase is sky high, but the lipase remains perfectly, reassuringly normal.
That is such a specific, crucial distinction. It is the literal difference between diagnosing an eating disorder behavior and diagnosing a potential surgical emergency.
Exactly.
All right, let's pivot our focus. We've seen how the internal metabolic machinery can break down. Now let's look at the systemic intruders, the external pathogens and the immune system gone rogue.
The great masqueraders.
Yes, this section of the text is aptly called the great masqueraders. We're talking about external forces physically hijacking the brain's hardware.
The blood-brain barrier is a formidable fortress, but when an infectious agent manages to breach it and enter the central nervous system, the psychiatric manifestations can be incredibly severe and abrupt.
The text provides a truly chilling case study about herpes simplex virus, or HSV encephalitis.
Yeah.
I'll walk us through it because the diagnostic bias here is fascinating.
It's a classic example of diagnostic overshadowing.
Right. So a 49-year-old homeless male is brought to the A&E by ambulance. He's well known to the psychiatric service. He has a documented, long-standing history of bipolar I disorder. On presentation, he has a witnessed seizure, a fever of 39 degrees Celsius, and a heart rate in the 120s. He is severely agitated, his speech is completely unintelligible, and he appears to be actively responding to internal stimuli hallucinating.
So if you look at this patient exclusively through a psychiatric lens, what do you see?
You see a homeless man with known bipolar disorder who is probably non-compliant with his medication, acutely manic, and floridly psychotic.
Right. You might be incredibly tempted to administer a heavy intramuscular dose of haloperidol, sedate him, and ship him off to the inpatient psychiatric ward to sleep it off.
But doing that would be a fatal error.
Completely fatal, because his psychiatric history is actively blinding the clinician to a screaming acute medical emergency. You must look at the vital signs and the neurology.
The fever and the seizure.
He has a high fever, he just had a new onset seizure, and he has aphasia. His speech isn't just pressured, it is structurally unintelligible. Those are focal neurological signs, not psychiatric symptoms.
So the medical team wisely performs a lumbar puncture to extract cerebrospinal fluid, the CSF, from his spinal canal.
Yes, and the CSF analysis shows an elevated white blood cell count of 121 cells per microliter, predominantly lymphocytes, alongside a mild protein elevation.
Which indicates what?
This is a classic viral profile. They run a PCR and identify HSV1 DNA in the fluid. The herpes simplex virus is literally necrotizing, destroying his temporal lobes.
Oh my God.
The temporal lobes govern memory, language comprehension, and limbic emotional regulation. That structural destruction is exactly why he is psychotic, agitated, and aphasic.
So it's actual brain damage causing the symptoms?
Yes. Because they caught it, they treat him with intravenous acyclovir, an antiviral, and he eventually recovers to his baseline. If he had gone to the psych ward, his brain would have herniated.
That case terrified me because it shows how easily a label like known bipolar can obscure a deadly reversible brain infection. What other infections are we aggressively looking for? Syphilis is the historical classic, isn't it?
Tertiary neurosyphilis is the original great masquerader of psychiatry. Before the discovery of penicillin, psychiatric asylums were filled with patients suffering from advanced syphilis.
Right.
The spirochete bacteria, Treponema pallidum, can lie dormant for decades before invading the brain, manifesting as rapid-onset dementia, grandiose mania, or bizarre psychosis.
How do you diagnose it properly today?
You have to understand the mechanism behind the screening cascade. You don't just order one test. You start with non-treponemal tests, like the RPR, which stands for rapid plasma radion,
Right.
or the VDRL.
Why are they called non-treponemal? Are they testing for the bacteria?
That's the trick. They aren't testing for the bacteria itself. They're testing for antibodies against cardiolipin, a lipid that is released by cells when they are damaged by the syphilis bacteria.
Ah.
Because these tests are looking for a marker of cellular damage rather than the pathogen, they are cheap and fast, but they are notorious for false positives.
For instance?
If a patient has systemic lupus erythematosus, their immune system is damaging their own cells, releasing cardiolipin, which makes the RPR test flag positive even though they don't have syphilis.
Ah, there's Bayes' theorem in action again. So if the RPR is positive, you don't just immediately diagnose syphilis and prescribe penicillin.
Correct. You must confirm that preliminary finding with a specific treponemal test like the FTA-ABS. This test looks for antibodies that the immune system has specifically designed to target the actual Treponema pallidum spirochete. It confirms the infection.
And what about neurosyphilis?
Crucially, if you suspect the syphilis has already entered the brain neurosyphilis, a blood test isn't enough. You must perform a lumbar puncture and run a VDRL directly on the cerebrospinal fluid itself to see if the central nervous system is compromised.
And HIV. We don't often associate HIV with primary psychiatric presentations, but the text suggests otherwise.
HIV is a profound mimic. In the acute seroconversion stage, right after infection, it might just present as vague malaise, headache, and mild mood changes.
Like a cold?
Yeah. But chronic HIV infection, especially if untreated, allows the virus to infiltrate the central nervous system via infected macrophages crossing the blood-brain barrier.
Leading to what?
This leads to HIV-associated neurocognitive disorders, or HAND. Even in our modern era of highly active antiretroviral therapies, up to half of all HIV-infected individuals show some subclinical level of cognitive impairment.
Half. That's significant.
Yes. Furthermore, the virus can disrupt subcortical circuits, presenting abruptly as acute, uncharacteristic mania or severe treatment-refractory depression.
So an infectious agent can fundamentally rewrite someone's personality. Which brings us to the internal defense system going rogue. Autoimmune and inflammatory encephalopathies.
This is undoubtedly one of the most rapidly expanding, revolutionary frontiers in modern psychiatry. We're increasingly discovering that a significant subset of what we historically categorized as primary psychiatric illnesses, treatment-resistant schizophrenia, bizarre bipolar presentations, are actually devastating autoimmune disorders,
Where the body attacks itself.
where the patient's own antibodies are mistakenly attacking the synaptic receptors in their brain.
Let's start with systemic lupus erythematosus, SLE. This is a systemic autoimmune disease affecting multiple organs.
Lupus is characterized by chronic systemic inflammation. The immune system attacks the body's own DNA. About 5% of patients with SLE will experience frank, horrifying psychosis directly caused by the autoimmune inflammation of the brain tissue.
And depression.
Profound depression is incredibly common. Clinicians track the systemic disease activity by measuring anti-double-stranded DNA antibodies. When those specific antibody levels spike in the blood, it means a severe inflammatory flare is imminent.
But there's a vicious double-edged sword here with lupus treatment, isn't there? The cure can mimic the disease.
Yes, and it creates a nightmare scenario for the psychiatrist. The gold standard treatment for a severe organ-threatening lupus flare is high-dose corticosteroids like prednisone.
Okay.
However, high-dose steroids themselves can induce severe chemically driven depression, frank psychosis, or what we call steroid-induced mania.
So imagine you are paged to the medical ward to consult on an SLE patient who has suddenly become paranoid and manic.
You face a terrifying clinical dilemma. Is the lupus inflammation attacking their brain directly, known as lupus cerebritis, Or are the massive doses of steroids saving their kidneys currently causing a manic psychosis?
How do you even tell?
It's extremely difficult. The treatment for one is more steroids. The treatment for the other is stopping the steroids. It requires intense, multidisciplinary coordination.
That brings us to what might be the most fascinating and terrifying condition, detailed in the entire text: anti-NMDA receptor encephalitis. The textbook dissects this critical clinical presentation meticulously.
It is a devastating disease. It was only formally identified relatively recently, but it has fundamentally changed how we view new-onset psychosis.
Who does it typically affect?
Typically, though not exclusively, it affects young adult females. They present with a viral-like prodrome, a headache, a mild fever, followed by an abrupt, shocking onset of extreme mood lability, severe paranoia, and prominent auditory and visual hallucinations.
So to any psychiatric clinician, it looks exactly, flawlessly like a first-episode schizophrenia.
Exactly. But unlike schizophrenia, it doesn't stay purely psychiatric. It rapidly progresses into a neurological nightmare.
How fast?
It accelerates terrifyingly fast. Within days or weeks of the psychiatric onset, they develop profound cognitive impairment and mutism. Then comes autonomic instability. Their blood pressure and heart rate swing wildly.
Oh, wow.
They develop bizarre, stereotyped movement abnormalities, like intense facial dyskinesias, grimacing, or chorea, and eventually they develop severe seizures and slip into a coma.
What is actually causing this?
The underlying mechanism is that their immune system is producing specific IgG antibodies that cross the blood-brain barrier and bind directly to the NMDA receptors.
And what do those receptors do?
These receptors, which rely on glutamate, are absolutely crucial for learning, memory, and basic reality testing. The antibodies essentially rip the receptors out of the synapses.
The text gives a heartbreaking but illuminating case study to highlight the diagnostic process here. An 18-year-old female, absolutely no past psychiatric history whatsoever.
Right.
She shows up in the A&E with abrupt paranoia, echolalia, which is compulsively repeating the clinician's words back to them, and occasional bizarre flailing movements of her arms.
The clinical clue is in the collateral history. Her father reports she had a generalized tonic-clonic seizure the day before she was brought in.
Again, just like the HSV case, the seizure is the glaring red flag.
Primary schizophrenia does not cause tonic-clonic seizures. An EEG is ordered, and it shows epileptiform discharges, indicating generalized electrical irritability.
And then they test the fluid.
They do a lumbar puncture. The CSF doesn't show a massive infection, but it does have a mildly elevated white blood cell count of 18 and a modestly elevated protein level signs of mild persistent inflammation.
They ultimately test that CSF for autoimmune antibodies, and it comes back positive for IgG antibodies against the NMDA receptor. But here's the part of the mechanism that completely blew my mind.
The ultrasound.
Yes. When they confirm that diagnosis, what diagnostic test do they have to prioritize immediately? It's not a higher resolution brain scan.
It's a pelvic ultrasound.
Why on earth are we rushing a violently psychotic young woman to get a pelvic ultrasound? It seems completely disconnected from the brain.
It's an incredible example of systems biology. In a significant percentage of these young women, the original trigger for this massive autoimmune attack on the brain is an ovarian teratoma.
Teratoma, what is that?
It is a specific, bizarre type of germ cell tumor that can differentiate into various tissues: hair, teeth, and crucially, neural tissue.
Oh, wow. So you have a tumor growing in the ovary that contains ectopic brain tissue.
Yes. The body's immune system detects this rogue brain tissue in the ovary, recognizes it as abnormal, and mounts a massive antibody attack to destroy the tumor.
However, those antibodies don't just stay in the pelvis.
No, they don't. They enter the bloodstream, cross the blood-brain barrier, and attack the patient's actual healthy brain.
It is immunological friendly fire on a catastrophic scale. The body is trying to cure a tumor and destroys the mind in the process.
Exactly. And understanding that mechanism completely dictates the treatment. The treatment for anti-NMDA receptor encephalitis is not to prescribe heavy doses of antipsychotics,
which might actually worsen their movement disorders.
Right. The primary treatment is the surgical removal of the ovarian teratoma to stop the production of antibodies at the source.
And then what?
This is followed by heavy immunosuppression, massive doses of steroids, intravenous immunoglobulin, or plasma exchange.
Which literally involves filtering the patient's blood through a machine to physically wash the destructive antibodies out of their system.
Yes. If you misdiagnose this as standard schizophrenia and just lock them on a psychiatric ward, they will likely die from autonomic failure, respiratory collapse, or status epilepticus.
That is the ultimate undeniable example of why we have to look at the projector, not the screen. Let's briefly touch on nutritional and genetic clues before we move into treatment integration. Let's talk about Wilson disease.
Wilson disease is an autosomal recessive genetic disorder. The patient is born with a genetic mutation that causes the body to lose its ability to metabolize and excrete copper.
Copper from food.
Yes. We all ingest trace amounts of copper in our diet. In a healthy person, the liver processes it and excretes the excess into the bile. In Wilson disease, this transport mechanism fails.
So where does the copper go?
The copper builds up, deposits heavily in the liver, gradually destroying it through cirrhosis, and crucially, it escapes into the blood and deposits in the basal ganglia of the brain.
Which controls movement.
The basal ganglia coordinate movement and influence cognition. This copper toxicity causes severe movement disorders, profound personality changes, and frank psychosis, usually presenting in a patient's late teens, 20s, or 30s.
And what are the specific lab tests to catch this copy buildup?
You look for two things. First, a low serum ceruloplasmin. Ceruloplasmin is the main transport protein for copper in the blood. It's abnormally low in Wilson disease. Second, you look for a massively elevated 24-hour urine copper level. Because the liver can't excrete the copper into the bile, the free copper spills into the blood and the kidneys desperately try to filter it out into the urine.
And the eye rings, right?
Yes. You can also look for Kaiser-Fleischer rings, which are copper deposits in the cornea of the eye.
And nutritionally, the text heavily emphasizes looking out for thiamine and vitamin B12.
Yes. Thiamine, or vitamin B1, is an essential cofactor for glucose metabolism in the brain. The brain runs on glucose, and it needs thiamine to process it.
Why do people get deficient in it?
Thiamine deficiency is rampant in chronic alcohol abuse due to poor diet and intestinal malabsorption. This deficiency leads to Wernicke encephalopathy.
What does that look like?
It is an acute, life-threatening neurological syndrome characterized by a triad of symptoms: profound confusion, ataxia, which is an unsteady stumbling gait, and ophthalmoplegia, which is paralysis of the eye muscles.
Is it reversible?
If you catch it early and administer intravenous thiamine, it is reversible. If it goes untreated, the thiamine starvation causes permanent microhemorrhages in the mammillary bodies of the brain, progressing to Korsakoff syndrome.
Which is permanent.
This is an irreversible, devastating anterograde amnesia where the patient physically cannot form new memories and frequently confabulates to fill the gaps.
What about B12?
B12 and folate deficiencies are also critical. They are essential for DNA synthesis and maintaining the myelin sheath around nerves. Deficiencies here can present slowly as peripheral neuropathy, dementia, severe depression, or psychosis.
The text mentions a nuance about testing for B12, actually.
Yes, interestingly, the text notes a specific diagnostic nuance. If serum B12 or folate levels are borderline and ambiguous, you can measure methylmalonic acid and homocysteine levels.
What are those?
These are metabolic intermediaries that require B12 and folate to be processed. If the vitamins are truly deficient at a cellular level, these intermediaries will predictably back up and elevate in the blood, confirming the diagnosis.
This brings us to the integration and clinical reasoning section. Knowing these physiological interlopers exist is only half the battle.
The other half is treatment.
Right. Ensuring the very treatments we prescribe as psychiatrists don't inadvertently cause the physiological chaos we just spent the last hour discussing. We have to monitor the machine while we tinker with it. Let's start with structural imaging of the brain. The text discusses CT versus MRI versus EEG.
The cardinal inviolable rule here is that we do not use structural brain imaging to make psychiatric diagnoses. There is no CT scan that diagnoses bipolar disorder. There is no MRI pattern that definitively diagnoses major depressive disorder.
We use these incredibly advanced tools strictly to rule out non-psychiatric structural diseases.
Like tumors or bleeds that are masquerading as psychiatric presentations.
So if a patient comes into the A&E, acutely altered, aggressive, and psychotic, how do we choose between ordering a CT scan and an MRI?
It is an entirely hypothesis-driven choice based on physics. The clinical question you need answered drives the selection of the technology.
Let's start with CT.
A CT scan, or computed tomography, uses ionizing X-rays to create cross-sectional slices of the body. It is incredibly fast, taking only minutes, and it is less expensive. Because of how X-rays work, CT is absolutely brilliant at visualizing bone density and acute fresh blood.
So trauma.
Yes. So if your acutely altered patient has signs of head trauma Or if you suspect an acute subarachnoid hemorrhage or a subdural hematoma, you order a non-contrast CT. You need to see if there's blood pooling in the skull, and you need to know immediately.
But if they don't have trauma, if you're looking for something more subtle, like multiple sclerosis,
If you need high-resolution tissue detail, a CT is inadequate. You need an MRI, magnetic resonance imaging. MRI uses immensely strong magnetic fields and radiofrequency pulses to manipulate the protons in the water molecules of your body.
no radiation.
There is no ionizing radiation. An MRI provides exquisite detail of soft tissue. It is essential if you're hunting for non-meningeal neoplasms, delicate vascular malformations, or specifically white matter hyperintensities.
What are those?
Those hyperintensities are the anatomical hallmark of demyelinating disorders like multiple sclerosis, where the immune system is stripping the insulation off the neurons. MRI is also vastly superior for examining the medial temporal lobes, which are highly epileptogenic and deeply linked to psychiatric symptoms.
If MRI is so much better at looking at tissue, why don't we just use it for everything?
Because it is slow, often taking 45 minutes, requiring the patient to lie perfectly still in a loud claustrophobic tube, which is nearly impossible for an agitated psychotic patient without heavy sedation.
And the magnets.
Furthermore, because it is a giant magnet, it is absolutely contraindicated if the patient has certain metallic implants, like an older pacemaker, as the magnet will literally rip the device out of their chest or heat the wires to the point of burning tissue.
That makes perfect sense. What about the EEG? The electroencephalogram. We are looking at structure there. We are looking at real-time electricity.
Exactly. The EEG records the spontaneous electrical activity of the cerebral cortex via electrodes placed on the scalp. We use it primarily to rule out seizures.
Even if they aren't shaking.
Specifically, we are looking for non-convulsive status epilepticus. This is a terrifying state where the patient is profoundly altered, unresponsive, or bizarrely psychotic, but they are not physically convulsing. Their brain, however, is locked in a continuous electrical seizure.
Wow.
We also use EEG to evaluate the severity and etiology of delirium. For example, if a patient is delirious due to severe liver failure, as we discussed earlier, the EEG might show triphasic waves, which are highly characteristic of hepatic encephalopathy.
Or for dementia.
Or, in a rapidly progressing dementia, you might see periodic sharp wave complexes, which strongly suggest Creutzfeldt-Jakob disease, a uniformly fatal prion disorder.
But there is a major caveat with EEG, isn't there?
Yes, a normal EEG recording between episodes does not definitively rule out a clinical seizure disorder.
Now let's return to the heart. We talked about potassium and magnesium, but let's talk about our own medications. The ECG, the electrocardiogram, and specifically the QTC interval.
This is critical.
The text relentlessly emphasizes that many of our most common psychotropic medications prolong this interval. Why is this prolongation so terrifying? What is physically happening in the heart?
To grasp this, you have to picture the cardiac cycle. The QT interval on an ECG represents the total time it takes for the heart's massive lower chambers, the ventricles, to electrically fire depolarization, and then fully recharge their electrical gradient repolarization, so they're ready for the next beat.
And the C in QTC?
The C in QTC just means it is mathematically corrected for the patient's heart rate. If a psychiatric drug blocks the potassium channels in the heart, which many do, it prolongs this interval, it means the ventricular recharge period takes abnormally long.
And why is a long recharge period so dangerous? Does it just slow the heart rate down?
No, it creates a window of electrical vulnerability.
Yeah.
During the very end of that prolonged recharge phase, some of the cardiac muscle fibers are ready to fire again, while others are still resetting.
So it's unsynchronized.
It creates electrical heterogeneity. If an ectopic, premature electrical beat misfires and hits the heart exactly during this vulnerable, chaotic window, a phenomenon known as an R-on-T phenomenon, it triggers a vicious, self-sustaining circular electrical current in the ventricles.
And what is that called?
This is polymorphic ventricular tachycardia, known medically as torsades de pointe.
Which translates from French to twisting of the points.
Yes, because if you look at the ECG monitor during this event, the waveform literally appears to twist spirally around the baseline. The ventricles are quivering chaotically at 200-250 beats per minute.
Oh my.
They are entirely disorganized and are effectively pumping zero blood to the brain or body. If it does not spontaneously resolve or is not immediately defibrillated, it degenerates into ventricular fibrillation and sudden cardiac death.
So who is at the highest risk for this? If we are prescribing a drug that we know prolongs the QTC like haloperidol, ziprasidone, or even citalopram, what are the specific red flags we have to calculate?
The risk factors compound heavily upon each other. A baseline QTc interval already greater than 450 milliseconds is a major red flag. Advanced age, particularly over 65, and especially over 75, as the heart's conduction system naturally degrades.
Yes.
Female sex carries a higher baseline risk. A history of structural heart disease, like congestive heart failure or a previous myocardial infarction. Bradycardia, a slow heart rate, actually prolongs the QT further.
And electrolytes, right?
And crucially, as we spent so much time discussing, concurrent hypokalemia or hypomagnesemia. If your patient has low potassium from a diuretic and you give them an intravenous dose of haloperidol, you are actively inviting torsades.
That's a recipe for disaster.
If a patient has multiple compounding risk factors, you must aggressively weigh the massive risk of sudden cardiac death against the psychiatric benefit of the medication.
As you listen to this next part, I want you to think of these monitoring guidelines not as a rote list of labs to memorize for an exam, but as logical, inevitable consequences of the drug's specific biological mechanisms.
We are building a mental model of safe prescribing.
Exactly. Let's start with the workhorses of modern psychiatry. Atypical antipsychotics, the second-generation drugs like olanzapine, quetiapine, or risperidone.
The major overarching liability of atypical antipsychotics is metabolic syndrome. While they are less likely to cause movement disorders than older drugs, they profoundly mechanistically alter insulin sensitivity, glucose metabolism, and lipid processing.
And weight gain.
Yes, they often cause rapid massive weight gain by altering satiety signals in the hypothalamus. Therefore, your laboratory monitoring must anticipate and track that metabolic disruption.
So what are we tracking?
You must obtain a fasting lipid panel, a hemoglobin A1C or fasting glucose to check for insulin resistance, and an accurate body mass index at baseline. You repeat these metrics at 12 weeks and then annually.
Because you are not just treating psychosis.
Yeah.
You are actively trying to prevent the patient from developing iatrogenic physician-caused type 2 diabetes and atherosclerotic cardiovascular disease.
Precise.
Clozapine requires its own highly specific model, doesn't it?
Yeah.
It is arguably our single most effective antipsychotic for treatment-resistant schizophrenia, but it comes with a formidable, legally mandated monitoring regime.
Yes, clozapine is unique. Its primary, most feared toxicity is agranulocytosis.
What is that?
This is a catastrophic, potentially fatal idiosyncratic reaction where the bone marrow simply stops producing neutrophils, which are the white blood cells that fight bacterial infections.
So they lose their immune system.
It effectively strips the patient of their immune system, leaving them vulnerable to overwhelming sepsis. Because of this, we mandate absolute neutrophil count, or ANC, monitoring via a blood draw.
How often?
The schedule is rigorous, weekly for the first 6 months, then every 2 weeks for the next 6 months, and eventually every 4 weeks indefinitely for as long as they are on the drug. If the ANC drops below a specific threshold, the drug must be stopped immediately.
But the textbook also highlights another, perhaps less appreciated, clozapine risk with a fascinating case study. Let's look at the 36-year-old woman.
This is a vital case for clinical reasoning. The 36-year-old woman with severe schizophrenia is finally started on clozapine. 1 month later, she presents to the A&E.
What are her symptoms?
She's developed a high fever, severe tachycardia, a fast heart rate, and dyspnoea, which is significant shortness of breath. The primary medical team assumes it is neuroleptic malignant syndrome, or NMS, a common reaction to antipsychotics because of the fever and the heart rate.
But the consulting psychiatrist spots something.
The psychiatrist astutely notes the negative findings. She doesn't have the severe muscle rigidity characteristic of NMS, and crucially, her mental status is completely clear. She is breathing fast, but she is lucid.
So if it isn't NMS, what was the mechanism driving the fever or the shortness of breath?
The psychiatrist correctly deduced that this was clozapine-associated myocarditis, an acute allergic-type inflammation of the heart muscle itself.
How do they confirm that?
They immediately ordered an ECG and checked cardiac troponins. Troponins are structural proteins inside cardiac muscle cells. If the heart muscle is inflamed and dying, troponins spill into the blood.
And were they high?
The troponins were highly elevated, confirming heart damage. An echocardiogram showed new-onset left ventricular dysfunction. Her heart was failing to pump blood effectively, which caused fluid to back up into her lungs, resulting in the shortness of breath.
So clozapine didn't just pose a risk to her white blood cells, it triggered an inflammatory attack directly on her myocardium.
Exactly. The clozapine was stopped immediately, and she was treated for heart failure.
What about lithium? We mentioned it earlier regarding calcium in the parathyroid.
Lithium is a simple heavy metal salt. It is not metabolized by the liver at all. It is cleared entirely, 100%, by the kidneys.
And it has a narrow therapeutic window.
A notoriously narrow therapeutic index. The target serum level is generally 0.6 to 1.2 milliequivalents per liter. If the level creeps just slightly above that, say to 1.5 or 2.0, you start seeing severe neurological toxicity.
Like tremors.
Coarse tremors, ataxia, delirium, and eventually seizures and renal failure. Because its clearance depends entirely on the kidneys, you must continually monitor renal function via blood urea nitrogen and serum creatinine.
And the thyroid.
Because it actively concentrates in the thyroid gland and inhibits hormone release, it can easily cause hypothyroidism, so you monitor TSH. And as we discussed at length, it stimulates the parathyroid, so you monitor serum calcium to prevent hyperparathyroidism.
Valproate. This is another major mood stabilizer and anticonvulsant.
Valproate is the metabolic inverse of lithium. It is heavily metabolized by the liver. Therefore, you monitor liver function tests for signs of transaminitis hepatic injury.
Yeah.
It can suppress the bone marrow, specifically causing thrombocytopenia, which is a dangerous lowering of platelets responsible for blood clotting. So you check a complete blood count.
And the ammonia we talked about.
And as we noted in the metabolic section, it can chemically inhibit the urea cycle in the liver, leading to high ammonia and subsequent encephalopathy. So you must have a low threshold to check a serum ammonia level if the patient becomes inexplicably lethargic or confused.
And then there's the oxcarbazepine case study, the 58-year-old woman.
Yes, she was a stable patient who was transitioned to oxcarbazepine for mood management. Just a month later, she develops acute, severe confusion and profound short-term memory loss.
She looked like she had dementia.
She was visibly drowsy during her clinic visit. The clinician ordered a basic metabolic panel, and her sodium had plummeted to an incredibly dangerous 118 milliequivalents per liter.
Severe drug-induced hyponatremia.
The medication fundamentally altered her kidneys' handling of free water, swelling her brain cells and perfectly mimicking a rapid-onset neurocognitive disorder. Stopping the drug and carefully correcting the sodium reversed the dementia.
Let's close out this integration section with what the textbook arguably presents as the ultimate psychiatric systems failure. Neuroleptic malignant syndrome, or NMS.
NMS is a rare, unpredictable, idiosyncratic, and potentially fatal reaction to neuroleptic or antipsychotic medications. It is a true psychiatric emergency.
What are the main symptoms?
It is classically characterized by a tetrad of severe clinical symptoms: altered mental status, severe lead-pipe generalized muscle rigidity, extreme hyperthermia with temperatures often exceeding 40 degrees Celsius, and profound autonomic instability.
Meaning blood pressure swings.
Wildly fluctuating blood pressure, drenching sweats, and extreme tachycardia.
What is actually happening physiologically to cause that cascade?
The prevailing mechanical theory is a sudden, massive dopamine blockade across multiple critical tracts in the brain.
Okay, dopamine blockade.
Dopamine blockade in the hypothalamus shatters the body's central thermoregulatory set point, causing the uncontrollable hyperthermia.
The fever.
Simultaneously, a severe dopamine blockade in the nigrostriatal pathways, the pathways that coordinate smooth movement, causes sustained, violent, unyielding muscle contraction, resulting in the lead pipe rigidity.
And that intense, continuous muscle contraction literally tears the muscle tissue apart.
Exactly. The muscles break down under their own sustained force in a process called rhabdomyolysis. This cellular destruction floods the bloodstream with a muscle enzyme called creatine kinase, or CK.
So a high CK is a hallmark.
Therefore, a hallmark defining laboratory finding in NMS is a massively, sometimes astronomically elevated CK level. But the danger doesn't stop there.
Why? What else happens?
The muscle breakdown also releases myoglobin, a large oxygen-binding protein. As the blood flows through the kidneys, this massive myoglobin molecule gets physically lodged in the delicate renal tubules, clogging them up.
Causing kidney failure.
This leads to myoglobinuric acute renal failure. The kidneys simply shut down.
What does the rest of the lab profile look like in this state of systemic collapse?
You will almost always see a profound leukocytosis, a stress-induced white blood cell count spiking dangerously between 10,000 and 40,000 cells per cubic millimeter.
And iron.
And interestingly, as a secondary marker, you frequently see an abnormally low serum iron concentration, though the exact mechanism for that is still debated.
How do we actually intervene and treat this?
The absolute first step is to immediately discontinue all offending antipsychotic medications. Then you institute aggressive, high-volume intravenous hydration to try and flush the myoglobin through the kidneys to prevent renal failure.
Alongside supportive care.
Intensive supportive care for the fever and blood pressure. Pharmacologically, you might administer dantrolene, which is a direct-acting muscle relaxant that works inside the muscle cell to stop the calcium-driven contraction.
Well, bromocriptine.
Or you might use bromocriptine, which is a dopamine agonist, to try and chemically reverse the massive dopamine blockade in the brain. Despite optimal care, the mortality rate remains significant. It is a catastrophic event.
This has been an incredibly dense, immensely complex journey, but so vital for clinical safety. Before we wrap up today's deep dive, we're going to transition to organically solidifying these mental models. Let's put ourselves directly in the clinician's shoes. We're going to discuss a few specific clinical presentations based on the chapter we just covered. Let's explore how these mechanisms dictate diagnostic reasoning. Are you ready?
Let's do it.
Case 1. Let's look at a concept and mechanism. Imagine you are the attending physician. A 22-year-old patient with severe anorexia nervosa, specifically the binge purge subtype, is admitted to your medical ward for refeeding. During the intake exam, she complains of profound, unremitting fatigue. You order a routine ECG, and it reveals flattened T waves and prominent U waves. Based on our discussion, which specific electrolyte abnormality is driving this electrical instability?
The culprit here is severe hypokalemia. The mechanism is clear. Her chronic purging via self-induced vomiting depletes her total body potassium. Because potassium is the essential ion for cardiac muscle repolarization, the physical lack of potassium delays that electrical reset. The myocardial cells literally take longer to ready themselves for the next beat. This delayed reset visually manifests on the surface ECG as those flattened T waves and the ominous emergence of prominent U waves. It is a critical warning sign that her heart is electrically primed for a lethal arrhythmia.
Spot on. Case 2. Let's focus on clinical reasoning and pharmacology. You are evaluating a patient in the outpatient clinic with a long documented history of severe alcohol use disorder. You order baseline liver function tests. They reveal an AST of 120 and an ALT of 50. You also note their serum albumin is markedly low. Given this profile, if you prescribe a standard dose of a highly protein-bound psychiatric medication like diazepam, what is the primary pharmacokinetic risk you are introducing?
The profound risk is severe, potentially lethal medication toxicity due to a massively increased fraction of unbound active drug.
Because of the SHIBs.
Exactly. The mechanism is evident in the labs. The AST to ALT ratio is greater than 2 to 1 to 50, which strongly suggests ongoing alcoholic liver disease damaging the mitochondria. Because the liver is failing, it cannot synthesize albumin.
So no cargo ships.
Because the drug you prescribed relies heavily on albumin cargo ships to transport it safely, the lack of those ships means a dangerously high percentage of the drug remains free or unbound in the plasma. Only the unbound drug can cross the blood-brain barrier. Therefore, your standard textbook dose will result in overwhelming toxic effects in the brain.
Case 3. Mechanism and manifestation. A 68-year-old female with bipolar I disorder has been impeccably treated with lithium for 20 years. She has been stable. She presents to your clinic with new onset cognitive dulling, anhedonia, severe depression, and vague physical weakness. You suspect a bipolar depressive relapse, but laboratory testing reveals profound hypercalcemia. What is the most likely underlying mechanism for this sudden shift?
The mechanism is lithium-induced hyperparathyroidism. Chronic, decades-long exposure to lithium can physically alter the parathyroid glands, causing them to oversecrete parathyroid hormone.
Pulling calcium from the bones.
This excess hormone relentlessly strips calcium from her bones and elevates her serum calcium levels. Hypercalcemia fundamentally depresses central nervous system electrical activity. This metabolic depression manifests behaviorally as severe lethargy, cognitive dulling, and depressed mood, which perfectly, but falsely, mimics a bipolar depressive relapse.
So treating her with an antidepressant would be useless.
Completely useless. She needs endocrine or surgical intervention for her parathyroid.
Case 4. This is a crucial one for differential diagnosis. An 18-year-old female university student presents with abrupt mood lability, terrifying new onset auditory hallucinations, and paranoia. Crucially, her father reports she had a generalized tonic-clonic seizure yesterday. Her cerebrospinal fluid analysis shows a mildly elevated white blood cell count. Given this constellation of symptoms, what specific diagnostic imaging tests should be prioritized to identify the potential root etiology?
The priority is not a brain MRI, it is a pelvic ultrasound.
Yeah.
This exact clinical picture, a previously healthy young female with abrupt florid psychosis, severe mood lability, and crucially, a seizure combined with CSF evidence of neuroinflammation, is highly suspicious for anti-NMDA receptor encephalitis.
The autoimmune attack.
The body's immune system is producing antibodies that cross the blood-brain barrier and physically attack the brain's NMDA receptors. Because we know that in a significant percentage of these cases, the autoimmune reaction is triggered by an ovarian teratoma containing ectopic neural tissue, the pelvic ultrasound is required to locate and subsequently surgically remove this tumor to stop the antibody production at its source.
Amazing. Case 5. Let's look at baseline investigations. A 76-year-old male with severe melancholic depression is being considered for treatment with a tricyclic antidepressant, or TCA. In his medical history, you note he has a history of congestive heart failure. What is the most critical baseline investigation required before you write that prescription?
You absolutely must obtain a baseline ECG to assess for pre-existing cardiac conduction abnormalities.
Because of the sodium channels.
TCAs are notorious for affecting cardiac electrical conduction. They block sodium channels in the heart. In an older adult, especially one with a compromised heart from congestive heart failure, underlying asymptomatic conduction blocks are highly prevalent. Adding a TCA could easily push a minor electrical block into a complete lethal arrhythmia.
And in an overdose.
Furthermore, if the patient were to overdose on the TCA, a widened QRS complex on the ECG greater than 100 milliseconds is highly predictive of imminent seizures and ventricular arrhythmias. You need to know his baseline electrical architecture.
Case 6. Differentiating severe drug reactions. A 36-year-old woman with severe schizophrenia started clozapine exactly 1 month ago. She presents to the A&E with a high fever, severe tachycardia, and dyspnoea. The junior doctor suspects neuroleptic malignant syndrome. However, her mental status is completely clear and lucid, and she has absolutely no muscle rigidity. Given this presentation, what is the most important laboratory marker to evaluate her current acute state?
You need to immediately order cardiac troponins. While fever and tachycardia in any patient on antipsychotics should always raise suspicion for NMS, her perfectly clear mental status and complete lack of lead pipe rigidity make NMS highly unlikely.
The timing is key too.
The timing presenting exactly 1 month after initiating clozapine therapy combined with shortness of breath strongly points to the mechanism of clozapine-induced myocarditis. Cardiac troponins are highly specific biomarkers released during active heart muscle damage. They must be checked immediately alongside an echocardiogram to confirm the myocardial inflammation before her heart fails completely.
Excellent. I hope diving deeply into those clinical scenarios helps solidify the intricate, life-saving mechanisms we discussed today. As we reach the end of our time exploring this material, I want to hand it over to the expert for one final thought to carry with you into the clinic.
We spent our entire careers meticulously mapping the mind. We learn the intricate diagnostic criteria of the DSM, we study the complex psychological defenses our patients employ, and we listen deeply to their personal narratives. But we must never, ever forget that the mind is fundamentally anchored to the wet biology of the body. The true highest art of psychiatry isn't just knowing when a symptom meets a diagnostic criterion. It is possessing the clinical humility to know when to close the psychiatric textbook and open the internal medical chart. It is maintaining the constant, rigorous curiosity to ask, what other systemic bodily functions are quietly whispering to the brain right now, waiting for medical science to translate the signal?
Here are the details of this episode.
Medical assessment and laboratory testing in psychiatry. Byline. Before we conclude that the mind is unwell, we must ensure the body is not speaking.